I'm Hiral Bhatt. We are bringing you live STEMI India 2018 from Lucknow. With me, I would like to introduce our guest, legendary cardiologist Dr. V.S. Narian. He is a professor and head of department KGMU. So let me begin by asking you, how do you find the management of STEMI is different from the Western countries?
See, ST segment elevation MI is the same all over the world. The ideal management today is to reperfuse the affected artery as soon as possible, within the first hour if it is possible. While this is possible in the West because patients are situated at short distances from specialty hospitals, this is not a possibility in India. People are situated in far-flung areas. It's a big country. Getting to a specialty hospital is a problem. There are traffic snarls, and there are so many delays in the patient getting from his place to the hospital. So that is the first hurdle. And therefore you lead to a loss of time in the management of STEMI, because time is muscle. Now the other problem is that even when they reach the hospital in time, there are some economy issues. People don't have enough funds to sort of immediately take care of the management, which is involving some cost. Therefore, the primary angioplasty part, according to the CREATE registry, in our country is minimal. Less than 5% of our patients will be able to get a primary angioplasty, while it is almost 100% in the Western world. So that is how things are different. Now what we can do about it is that most of these patients, if there is a delay of their getting to the hospital, they can get a thrombolysis done. Because if you thrombolize within the first hour or within the first 2 hours or even say 3 hours, then the results are almost as good. You're able to open up the artery and restore flow. And then subsequently, within the first 24 hours, you go ahead and dilate the stenosed artery. And this is what we call the pharmaco-invasive methodology. So in India, I think the emerging technology, the emerging management strategy is going to be pharmaco-invasive. That means lyse now and stent later. In the West, of course, thrombolysis is sort of going down, and more people are getting access to primary angioplasty. So that is the basic difference between the Western world and our country.
So, sir, what are the biggest challenges in management of STEMI as per the Indian context?
The ones which I just pointed out: time for the patient to get to the hospital, and when it gets to the hospital, the cost. And I think pharmaco-invasive strategy also involves cost. So what I was thinking was, and what STEMI India, this program which we're running for the last 5 years, which has come from the north and it is spreading to the other parts of the country in a big way, is that we have a hub and spoke model. We have several peripheral hospitals where thrombolysis is done the moment the patient reaches there, thrombolized, and then within the first 24 hours, this patient is shifted to the hub hospital where an angioplasty facility is available. Now for that, you need government machinery to pitch in, especially in our population where we have some economy issues also. And for that, in Uttar Pradesh, we have these 108 ambulances. The moment somebody gets a chest pain, he calls up the ambulance. That ambulance carries this patient to the hospital where either angioplasty is available, or if it is a long distance away, it takes him to a hospital where thrombolysis can be given. And once thrombolized, then this patient is shifted to a hub hospital, which have to be sort of funded also. So regarding the funding, in the West you have insurance coverage. So a methodology has been developed in the southern part of India, where you have identified that this is the total cost that is going to come for the entire population in that area. And some insurance company takes up the challenge and says, okay, we will fund this much money. But for that you need some premium. So that initial premium has to be promised by the government. When the patient is insured within that scheme, and the government pays for the premium for that population. So whoever gets an MI has access to all these facilities, and the payment comes through the insurance company, premium being paid by the government. So that kind of planning, I think, needs to come, and this is what we are going to propose to our government in Uttar Pradesh. And we have all the important people meeting tomorrow, where we can sit and bring out a strategy so that we can save more and more young lives, because in the state of Uttar Pradesh and in most of India, young people are getting MI. And for a young person to get an MI and to lose his life means loss of so many productive years. So on the long run, we need to save lives of the younger population by giving them some program with STEMI India life program, so that we can help them and save their lives.
So, sir, what are the key highlights of STEMI India 2018?
We are actually working at a program where we would train the nurses, the technicians, the doctors, and the specialists to come into that program, the so-called heart attack management team, which is totally geared to meet the need of this growing epidemic of heart attack. The nurse should be aware, the doctor in the emergency should be able to diagnose it, the pharmacist should be able to administer thrombolysis at a very rapid rate, and the specialist doctor should be available to do the angioplasty. So this one entire program we have to build up as a team, and this is what we are planning to do. And this is the key message of STEMI 18, to educate the entire group of people who will form a team, the heart attack management team, and the funding, etc., of course, will be discussed, as I said, tomorrow.
Thank you so much, sir, for joining
Thank
us
you.
on live platform of STEMI India 2018.